Welcome, everyone. My name is Ron Ackerman. I'm the director for the Institute for Public Health and Medicine at Northwestern University, and I want to thank you for joining us today for our IFAM webinar series. We have a special guest today. I'm excited to introduce him and want to just give you a few logistics. Again, if you're joining by Zoom, we do not monitor the chat function for questions, but if you have questions of our presenter, we encourage you to enter them using the Q&A button on the bottom of your Zoom screen. Time permitting, at the end of the presentation, we'll go through those questions and ask Dr. Semenza to address them in order. So please do use the Q&A function. We encourage you to be interested in asking those questions at any point throughout the presentation. Dr. Daniel Semenza is Assistant Professor, Department of Sociology, Anthropology, and Criminal Justice, and the Department of Urban Global Health at Rutgers University. He's also the Director of the Interpersonal Violence Research, New Jersey Gun Violence Research Center. Dr. Semenza's presentation today, titled Gun Violence Exposure and Community Health, Considering Reciprocal Neighborhood Dynamics, will discuss the results of an ongoing study on the reciprocal and longitudinal relationship between community gun violence exposure, concentrated disadvantage, and multiple aspects of collective health in nearly 16,000 neighborhoods across 100 US cities. Dr. Semenza, we're delighted to have you with us today, and the floor is yours.
Awesome. Thank you so much, Ron. I appreciate that introduction. And thank you, everybody, for being here and attending this. I'm really excited to be able to talk with you all. And so I have planned, roughly a 40-ish minute presentation. But I do want to leave time for ample questions and feedback. Right? Some of this is ongoing work, and I'd love to have people's thoughts, ways we can make it better or improve on some of the things that we have or have not considered, because it's pretty expansive. And so hopefully we can have a conversation after all of this is said and done. So before I get into the presentation, Ron gave a little bit of my background, and I just want to give you a sense of where I'm coming from. So I am currently in 2 different departments across multiple campuses in Rutgers University, and I work at the New Jersey Gun Violence Research Center, which is based at Rutgers. My PhD is in sociology, but now I'm in a criminal justice and a public health kind of environment. And so this project is really built out of that kind of interdisciplinary focus and approach. In thinking about kind of collective health and thinking about community exposure, rather than thinking solely at the individual level, I am trying to pull together the knowledge and the insight that comes from a few different disciplines. And so hopefully you'll be able to get that a little bit from the presentation, but I'm certainly happy to talk more about this interdisciplinary approach should it come up. Okay. So I want to start with just contextualizing a little bit about where we are right now in 2023. I've been spending a lot of time just in the last week talking to people about the shooting in Nashville. But it seems like every day there are additional things to talk about when it comes to gun violence in America, whether that's actual shootings or response to those shootings, and the different struggles we're having with addressing them as a country. So in 2021, which is the year that we have kind of the best data for right now, nearly 49,000 people in the US died from a firearm injury, and that's from data from the CDC. 49,000 people, it really is a tremendous toll. Roughly 2/3 of those represent suicides, people dying by suicide with a firearm. But it's also really important to contextualize this to understand that all the best research we have, because we don't monitor this currently in a completely legitimate way with governmental statistics, is that more than roughly 2,000 times those killed by a firearm are non-fatally injured. And so we're looking at kind of almost a magnitude of more people who are shot but will survive the injury. Roughly 70 to 80% of people who are shot with a firearm will go on to survive their injury. And that's really, really important for thinking about this presentation today. When I talk about exposure, it goes far beyond the individual who was shot and the people who know that person, but it also really has to take into account non-fatal firearm injury as well. So contextually, according to the data that the best data that we have, we're talking about some of the highest homicide rates in roughly 30 years in a lot of places. And in some cities like Philadelphia, where I live near, it's the highest homicide and shooting rates in history. And so in some ways, we're talking about an unprecedented time for community gun violence exposure and the number of people who are impacted by this on a day-to-day basis. Now, firearm injuries, another thing that you've probably been hearing in recent weeks or months, is that gun violence injuries are now the #1 leading cause of death for children in the United States from 1 to 18 years old. This is, again, something striking that no matter how many times I say it, no matter how many times I hear it, it still feels unreal. This started to happen a couple years ago, where the leading cause of death by firearm injuries started to eclipse motor vehicle accidents as the #1 cause. And that trend has kind of continued as vehicle deaths have gone down, firearm injuries have gone up amongst children. And so there's a real urgency here, in my opinion, to what we're talking about. And not only is there the toll, in terms of death and injury, but we're also talking about an astronomical financial toll. There was an article that came out last year in JAMA that did, I think, a pretty solid job at estimating what type of costs we're looking at. Somewhere to the tune of $550 billion each year in the United States when you're accounting for immediate healthcare costs, post-injury and death costs related to healthcare and kind of longitudinal care, people who survive, and then, of course, taking into account the much broader types of quality of life considerations, revenue and productivity losses and things like that. So even if you were to take those out, we would still be talking about many billions of dollars a year. But when you consider kind of the broad scope of things, the toll is enormous financially. And so I think it's really important to kind of contextualize that a little bit. But we also know that when we talk about firearm injury and we talk about gun violence in the United States, we're often talking about different things. People will talk about gun violence, in terms of like capital G, capital V gun violence, as if it's this one singular problem. But really, it's multiple different problems. An issue of mass shooting is very different than the issue of suicide in the United States, which is disproportionately impacting older white men who live in rural places compared to somewhere like homicide, which is by far and away disproportionately affecting younger Black men, both people who are committing shootings and people who are the victims of shooting. And so I think it's, again, just important to remember that the toll of this in some ways is unequal depending on the type of gun violence we're talking about. I am going to focus predominantly today on interpersonal gun violence, shootings that happen, either a homicide or an attempted homicide, right? But it's important to contextualize shootings and gun violence more broadly. And I just think this graphic does a really good job at showing, at the bottom, we're talking about age groups, and then on the left-hand side, the deaths per 100,000, you can see this enormous peak, especially between Black boys and men, roughly between the ages of, starts to spike up around 14 years old and really doesn't come down until much later in life. And is elevated at the risk of gun homicide across pretty much the entire life course. So we're talking about a vastly disproportionate impact that this is having on individuals, but we're also talking about a vastly different impact that this is having on whole communities. And so this is an analysis that I think did a really good job with visualization of the impact of gun violence and where it clusters alongside poverty rates in Chicago. This was a look at 2019 and 2020, just as a comparative of the increase that happened as a result of the pandemic. But you can see strikingly when you look at both years, the concentration of homicides, and again, we're just looking at homicides, not non-fatal shootings, which would, essentially blow this map up because we would be covered in dots. The homicides disproportionately are happening and clustering in areas that are, neighborhoods with higher rates of poverty. So the deeper blue the neighborhood gets, the higher the rate of poverty in that neighborhood. And also the higher percentage of Black and Hispanic individuals live there as well. Those tend to correlate very closely, especially in somewhere like Chicago. And then, not coincidentally, you also see the shootings that are clustering in many of these same areas. And so you're seeing clustering on Chicago West Side neighborhood, places like Humboldt Park, West and East Garfield Park, Austin and North Lawndale areas. These are some of the areas that are experiencing some of the highest rates of shootings. So again, thinking about community level or neighborhood level exposure, not only is the individual risk of being a victim of homicide with a firearm vastly different depending on the age group, the gender, and the race of the individual, but we're also talking about an issue of community composition where disadvantaged communities of color, in particular in the United States, are much more likely to experience high rates of gun violence exposure than their counterparts that are wealthier or that are whiter. And so that brings me to kind of the image that I'm almost at the risk of overusing and kind of taking the metaphor a little bit too far, but I think that the ripple effect of gun violence is really, really important to consider if we want to talk about the real impact that gun violence has in communities. And again, I'm talking largely today about interpersonal gun violence, where one person is assaulting another. And that's thinking about how gun violence and its impacts, including its health impacts, go far beyond the bullet that lands on a body, right? So if a person is shot, they are either killed or they'll survive the shooting. That is just the beginning of a real array of negative health outcomes that I'll talk about in a second, that expand to the loved ones of the person who has been victimized. It goes to the people that are living in their communities that might have heard about those shootings. And it also includes people who are survivors if somebody has died, kind of secondary homicide survivors. You can take this even further. It's harder to conceptualize, but thinking about how people are exposed to gun violence on a day-to-day basis, just by hearing about it in the news and social media, there is this real ripple and reverberation that happens every time a person is killed or shot non-fatally. So if you can, for the rest of this presentation, try to keep that ripple kind of image in the back of your head as you think through with me the mental and physical health impacts that I'm going to be discussing. Now, this is a model that I just wanted to kind of put in front of everybody as a conceptual way of thinking through the different levels of this reverberation or ripple effect. I'm still playing with this, and so I'll take feedback. One of the things I'm not loving is kind of the primary, second, tertiary exposure language, just because maybe that's confusing a little bit with public health. But for the sake of today, I wanted to present it to think about, well, like I said, the primary exposure, the way that somebody could be most directly affected by gun violence is they themselves are injured or they themselves are shot. But of course, there can be secondary exposure, family member, friends, personally knowing somebody who was shot or killed. There is a lot of good evidence that we'll get into that has health reverberations. And then tertiary exposure, living in a community where somebody might witness or hear about a shooting. They may not directly know the person, but they are familiar with them, or they know that they live a couple blocks away. And then so they're more exposed to people getting shot than somebody who doesn't live in a high violence neighborhood. And as you get further, you're kind of talking about further social distance from that initial bullet point, that shooting. And you're also talking about higher community prevalence, right? Because the further away, the more likely it is that people are going to know somebody in their social network or have heard about somebody in their neighborhood. And that just makes it more of a prevalent exposure than perhaps somebody who is personally injured or personally shot by a firearm. Okay, so I want to talk about mental health and physical health. I'm going to talk about them separately, but I also do think that there's a real need here to consider the impacts together, which is what I'll show today in my analysis. There's the bulk of the research on gun violence exposure, GVE, that's that abbreviation, has been related to the fallout when it comes to mental health. And so there have been a number of studies, some review studies that look at this. From a direct perspective, there's very, very rich ethnographic research that shows the anxiety, depression, PTSD, hypervigilance, all of these different symptoms of poor mental health that derive from being a victim of a shooting, right, and surviving it. But there's also some older research and now new emerging work on secondary survivors, people who know somebody who has been killed, or even just somebody who has been shot but survived, again, having an impact on fear and anxiety, the feelings of loss, the stress that comes with that, higher symptomology of depression. So there are a lot of different comorbid things that tend to cluster around those who survive. And one of the things that I think is starting to emerge increasingly is that this has a real impact on children in particular. So I told you at the beginning of this presentation that the firearm injuries are the #1 cause of death amongst children. But that does not take into account, again, all of these reverberating effects that it has for a child who loses a parent, a child who loses a sibling, or a child who loses a friend at school. And so more work has to be done in this particular area on children, but there's definitely research to suggest that this has real impact. And then finally, kind of on more broader neighborhood exposure levels, the influence that hearing about or witnessing or living in high violence neighborhoods has on enduring stress, chronic stress, what that does to allostatic load, and feeling like a person is always in this kind of fight or flight mode. And then additionally, I think it's really important to consider how this might weather people, how this consistently over time, that stress is beating down people, and that exposure is causing them to be more prone to illness, whether it's mental or physical health, because of the consistency of that violence exposure. So really at all these different levels, there's some work on mental health. The picture for physical health is far less clear. Again, most of this has been more around direct victims, ethnographic work that talks about, victimization and what that does for chronic pain, functional disability, increases in substance use, right? So there's a lot of ramifications for being a direct victim. And I think increasingly shown in the literature that there are ramifications for broader community exposure, particularly around health behaviors, that the stress of losing somebody, that the fear of witnessing or hearing about a shooting in your neighborhood can have real impacts on sleep, your desire or ability to go outside and get exercise, diet, and kind of related to exercise is increased rates of obesity. And then finally, kind of preventative health efforts. If you are living in an environment where there's a lot of violence, where you're exposed, where you become aware of this consistent threat all of the time, willingness to regularly go to the doctor, to go to exams, to get vaccines, to kind of engage in a lot of the preventative health efforts that can make whole neighborhoods healthier. That kind of broader level of community exposure can potentially have impacts on this. And so that second block down there about physical health and the fallout related to community exposure of violence, I think is less well established, which is one of the reasons that I'm here today. But there needs to be more work done on this area. And so I'm asking you to keep a couple images in your brain right now before I get into the data. First, you have the ripple effect image. You have the stone dropping into the lake, or the ramifications going outward from a shooting. The second is thinking about, if we're talking at a community exposure level, thinking about the real relationship between gun violence and health, and also how it corresponds to concentrated disadvantage. Now, concentrated disadvantage is a term or a kind of measure that we consider a lot in criminology. It's often conceptualized, and I'll show you in a second, as a combination of socioeconomic variables, percentage of individuals who identify as Black, percentage of households that are female-headed. So there are these different factors that correspond to one another that demonstrate disadvantage concentrated in a given neighborhood or a census tract for today's purposes. And there's lots of good research showing that concentrated disadvantage increases the risk of violence in a community, and some showing that it's related to community health. But concentrated disadvantage, as we know, plays an important role here because gun violence is going to be most likely to happen in places that are disadvantaged, in the neighborhoods that are hardest hit from an economic standpoint. And so a big question that I'm asking here with this study and kind of our ongoing work is, how do these things play together reciprocally? Not only how does concentrated disadvantage increase risk of gun violence, but how does gun violence then cycle back into compounding the concentrated disadvantage that a neighborhood is experiencing by making it harder for businesses to settle in, by increasing mobility amongst residents and making it harder for people to stay and build into a tax base. There are all these different mechanisms that you could think of. And then kind of also thinking about the reciprocal relationships between gun violence and community health, right? Poorer health, poorer sleep, poorer mental health can influence risk of violence, and then how those play also reciprocally with concentrated disadvantage. And so this is the kind of second image that I'll ask you keep in your mind as I present the results of the analysis. Okay, so in order to look at some of these things and to start getting at some of the more complex relationships that I'm talking about, what my colleagues and I did, and it includes folks here at Rutgers, it includes my colleague Ian Silver at the Research Triangle Institute, is we pulled together a database that is at the community or neighborhood level. So everything I'm talking about from here on is going to be talking not about individuals, but about neighborhoods, just to be very clear on the dynamics that I'm considering. And we created a database that pulled together some of the best data that we could find, first on gun violence. And we pulled that from the American Violence Project, which was conducted and pulled together by Pat Sharkey and his excellent team that pulls both fatal and non-fatal gun violence data from a number of sources, including the Gun Violence Archive, so that you can really get a sense of exposure at the census tract level. So that was really, really important once we were able to harness that. We combined this with information from the American Community Survey, demographic information, and then we married this with data from the CDC Places database, which I'm not sure if many people are familiar with. If you are, it's a fantastic tool because it gives you, again, census tract estimates of a wide range of health outcomes, again, at this neighborhood level, year over year. And so once we pulled these data together over the last year and a half, 2 years, what we ended up with was data on almost 16,000 census tracts across the largest, what is now the 99 largest US cities from 2014 to 2019. So we're talking about really a national data set when it comes to urban coverage of large cities, and a longitudinal data set of 6 years. That's the time frame that we're able to match all the data up, and hopefully we'll be able to continue to extend it. Okay, so gun violence is the number of shootings that are happening in the census tract. Again, this includes fatal shootings, which is accessible through a number of different resources, but more importantly, non-fatal shootings when somebody is not killed. We have data on that for all the census tracts in the database, and so we have this measure of total shooting in a given census tract year over year. Community health. Now, we took a kind of correlated traits approach where we look at neighborhood health, NH, broadly and think about the different constituent parts. So this is all the CDC places data. And we did some factor analysis and we played with the measures that hung well together. And these are kind of the factors that bore out. HB stands for health behaviors. So these are behaviors related to sleep, physical activity, and smoking. So it's the percentage of individuals who report poor sleep, less than 7 hours, not having engaged in physical activity, and being current smokers. So we are talking about a positive relationship. A higher prevalence of any one of these health outcomes indicates poorer community health. A little bit counterintuitive, but when it comes to coding and making everything match up apples to apples, that was the best way of doing this. So poor health behaviors, poor neighborhood health. Another component here is HS, health status, the prevalence of individuals who say that their mental health or physical health has been poor for more than 14 days over the last month. And then finally, this really interesting category of health prevention behaviors. And this is whether or not individuals have insurance, if they've gone and gotten a cholesterol screening, gone to the dentist, or gotten a number of core services. And this is for individuals over 65. So again, those over 65 are not typically going to be involved in gun violence, but they may be exposed in their community. So it's people who go out and get vaccines, fecal occult tests, colonoscopy, mammogram. And so there's really a diverse range here of thinking about health as a kind of main conglomerate, but also about the different types of health outcomes. I'm going to focus on neighborhood health today, but I have in an appendix all the models for these individual ones for those that are curious at the end. Okay, and the final main kind of piece of the triad is concentrated disadvantage. So again, we followed a lot of the literature on the constituent parts that make the most sense for thinking through concentrated disadvantage. And so this is from the American Community Survey, the percentage of families that live below the poverty line, those that are unemployed, those that identify as Black, and those that are headed by a female. And then finally, we include a number of time invariant controls. I won't get too much into these right now, but we did calculate the distance from every neighborhood using centroids to a level 1 or level 2 trauma center. And that really matters because it can shape whether or not a shooting goes from being non-fatal to fatal. Further away increases the risk for a shooting turning fatal. Percentage of individuals living alone, because we know that loneliness or lack of social support can correspond to poorer health. And then finally, the age and the gender composition of the neighborhoods. This is really to get at differences in health, but also differences in risk of criminal victimization and perpetration. And so these type of compositions help to just tease that out and control for those differences a little bit. Okay, and so here is our analytic strategy. We took a cross-lag panel modeling approach. And again, I'm going to talk mostly about total neighborhood health, which is that measure of the 3 main aspects combined. What this does, it allows to test reciprocal estimations between constructs. So we're looking year over year, and it allows us to say, for example, how does concentrated disadvantage influence health the following year? And then simultaneously, how does health influence concentrated disadvantage the following year? And when we picture this in a figure, you'll see how these cross relationships happen. It also allows for the residual covariation that is existing year over year between these three major kind of buckets that we're talking about. So that's a really nice kind of benefit of looking with a cross-lag panel approach. And what it does most importantly is it addresses a particular limitation on the CDC Places data. The CDC Places data uses a similar, if not the same, denominator for the population when it comes to the prevalence of a given health outcome in a neighborhood throughout the years of the data. It's kind of like a little weird, wonky thing about the data, which makes it hard to kind of address change over time, right? Because that you're not accounting for the denominator changing over time. Honestly, I don't think because of the way that populations change, it would make a huge, huge difference. But we want to make sure we get this right. We want to make sure that we are accurately looking at this year over year. And so rather than taking kind of a change approach, we took this cross-lag panel modeling with a reciprocal perspective that we thought really helped to address this. The second part of our analysis, again, that's going to be mostly in the appendix for today, is then breaking down these relationships by specific health construct, health status, behavior, and prevention efforts. And that's really important in the work that we're doing now, because we actually find, a little bit of a spoiler alert, that the results tend to cohere more so around status and behaviors. And finally, we looked at the lag reciprocal effects, which are built into the cross-lag panel models, but we pull those out to understand not just the link between gun violence and health, but also the link between concentrated disadvantage in this kind of triad that I'm talking about. So very briefly, here are some descriptive statistics. I don't want to focus too much on this or spend too much time, but you can see kind of the prevalence of the different health outcomes that we're talking about, the number of shootings on average in a given neighborhood. So of course, on average, it's going to be low, but if you looked at the range, you would see this range from anywhere from 0 to the 70 something. It's outrageous, obviously, where some of the very, very high shooting neighborhoods are going to have far, far more than the average. An average concentrated disadvantage score, and then the different covariates. Okay. I want to orient a little bit to what we're looking at, because I get it. There are a lot of arrows. The solid arrows are statistically significant relationships, and the dashed arrows are not statistically significant. The top and the bottom are essentially accounting for the year-over-year relationship between the same measure, so neighborhood health, just varying from one year to the next. That's less important to consider right now. The most important are these kind of crossing arrows, because that's when we get into the reciprocal nature of what we're talking about with the dynamics between these relationships. So overall, the best way to think about these models is not necessarily looking at any individual year, especially the first year, because we can't account for pre-2014. And so sometimes those results can be a little out of the norm. This one is a negative relationship, but the rest are positive, for instance. But really, it's about taking into these estimates as a whole and looking at the broad trends that we see across each year-over-year estimate. What we see here is that from one year to the following year, gun violence to neighborhood health, overall, we see a positive relationship consistently and significantly, where increased exposure to gun violence increases the prevalence of poor neighborhood health. Again, that kind of counterintuitive positive relationship. What we also see is that in 3 out of the 5 years, so not fully consistently, but 3 out of the 5 years, more often than not, poor neighborhood health also corresponds with higher rates of gun violence the following year. So this again is getting at that reciprocal effect year over year while accounting for covariance across all of these measures. It's complicated, but I also think it's really, really cool. And this is not tooting my own horn, this is tooting Ian's horn, my co-author, because he was able to come up with this kind of modeling approach, how it really allows you to think about these relationships while accounting for all kind of the covariance in between. So, takeaway here is that we do see evidence of a reciprocal effect, and the strongest evidence in particular for gun violence shaping or influencing neighborhood health the following year. And again, this is neighborhood health broadly conceived. Now I want to show you the results for concentrated disadvantage. There is, again, some evidence to suggest that concentrated disadvantage would correspond to neighborhood health, although it's complicated. Oftentimes it focuses predominantly on socioeconomic components. But overall, the takeaway here is that concentrated disadvantage has kind of a mixed relationship. You'll see some negative and some positive coefficients one year to the next. And so what that suggested initially to us is maybe there's not really a consistent thing happening here when we talk about how disadvantage in a neighborhood might make health worse. But when we looked at it individually, again in that appendix, what we found is that concentrated disadvantage is consistently and positively related to health status, right? How well you're feeling physically or mentally, and health behavior, sleep, smoking, and exercise. It's the health preventions, which are pretty diverse, that make the picture a little less clear. So I think as we're continuing to develop it, we're focusing a little bit more on those first two. But even when you include health prevention, right, what we see here is that poorer neighborhood health actually is associated with more concentrated disadvantage the following year. And this is much more consistent year over year, a positive relationship. Now, it's a small effect, but those small effects compounding concentrated disadvantage over time can result in much broader effects over time. And so again, we're having to do this year over year because of the uniqueness of some of the data. But this suggests that there is this interesting reciprocal relationship, and that the kind of back relationship on health's influence on subsequent concentrated disadvantage might be even more kind of regular or more consistent than we expected. And the final model that I want to show is the gun violence and concentrated disadvantage. Now, like I said, it's pretty well established in criminology that concentrated disadvantage increases the risk for crime, violent crime, and gun violence in particular. And we see that bear out very much so here. When there's more concentrated disadvantage in a neighborhood, the number of shootings are to go up significantly the following year. What's, I think, more surprising, and again, really contributes to this cyclical reciprocal understanding of how these neighborhood dynamics operate, is that when there's gun violence, more gun violence, it also is associated with increased concentrated disadvantage the following year. Again, small effects, but over time can be meaningful. And what I think this taps into is when you have violence in neighborhoods, it's really hard for those neighborhoods to get out of. It's hard to recover. It's hard for citizens and residents to establish themselves, for businesses to establish themselves, for families to feel safe and not want to move out quickly. So again, I'm doing this all the time with my students in my urban gun violence class. This stuff tends to work in cycles, and empirically, I think that's what we're seeing here with some of this modeling. Okay, so to summarize that, because I know lots of arrows, lots of numbers, across roughly 15,000 neighborhoods in 99 of the largest US cities, it was 100, but the data set now has 99. Gun violence corresponds to poorer overall community health. And we find that this is particularly driven by looking at health behaviors and health status. Poor community health and gun violence exposure is consistently associated with year-over-year higher concentrated disadvantage. So again, getting into this kind of triad. And then what I showed you at the very end is that concentrated disadvantage also strongly predicts gun violence, and especially aspects of poor community health related to health behavior and health status. So given that summary, here are some takeaways. And this is really what I want to, in addition to kind of other things we can do with this research, talk more about the takeaways here. I think what we're seeing here is that it's evidence of broader community impacts of gun violence on health, that the fallout extends beyond mental health, which is where a lot of the evidence has been, even though most of the evidence has been at the individual level, to include varied components of behavioral and physical health, which, when we're talking about concentrated disadvantage, has real implications for health disparities, because this is impacting communities of color that are living in concentrated neighborhoods the most. So gun violence is, I think, a really major mechanism for health disparities and widening gaps in health. And this starts to get at thinking through that a little bit. And so the kind of next logical take from that is that gun violence prevention is a form, and I would argue a very important form, of community health intervention. That if we want to reduce disparities, if we want to make health better, if we want to increase longevity of life, which is something that has been shortening in the United States, then violence prevention has to be a major component of a public health approach. And that could be through hospital-based violence programs. It could be through kind of group violence intervention or focused deterrence program, or street outreach programs, which I know there are a number of different excellent groups that are doing this work in Chicago, where many of you are today. So we can talk about specific programs, but these are, I think, more important than we give them credit for when it comes to community health. And so that requires urgency. It requires political action. It requires research action and research funding beyond what has already become available from the CDC, NIH, all of these different groups. And it requires financial action. It requires putting our money where our biggest problems are, right? Where our number one killer of children are, where our major mechanisms for worsening health are, according to this work and some of the other work that is out there, right? So we need to take a more urgent stance on thinking about gun violence as a really, really important component of community health. And so the next steps on this project, a few things that we've kind of proposed and are waiting on some grant funding for, to hopefully build this out further, is to expand data collection to lengthen the time frame, to go beyond 2019. We can't really go back before 2014 because the gun violence data gets very shaky, but to broaden this so that we could start assessing things like more chronic conditions, right? That if you're repeatedly over time exposed to gun violence, or you're exposed in 1 year and then you live 6, 7, 8 years down the line, what does the risk in a community for different types of chronic illnesses that might be mediated through pathways of behavioral health? We can't really look at too much of that now with a 6-year database, and so we want to just continue building this out. We also want to look at more neighborhood risk factors, including things like the natural and built environments in neighborhoods. We know this is really important for both health and gun violence, as well as issues of firearm access. What does firearm access look like from the number of gun stores that are in places, how proximate they are, how easy it is to get a gun, what kind of gun legislation is impacting different cities. All of these are really important contexts for the relationships I'm talking about today. And so relatedly, contextualizing this to the individual as well as the neighborhood, being able to find ways to link to individuals, I think is going to become critical. Not easy, would be expensive, I think, in trying to find some novel ways of doing it. And that's why I hope to continue to build new collaborations across disciplines, people who are in medicine, who are in public health, who are in lots of different diverse social sciences fields. This stuff is naturally interdisciplinary and will be strengthened from the minds of people who are thinking very differently on the issue, given its kind of enormity, but also its urgency. Thank you all so much for listening. Thank you all so much for being here. This is my contact information, my email, my Twitter, and then this is the New Jersey Gun Violence Research Center's website where you can follow our newsletter and you can stay in touch that way. So I look forward to our conversation and all of your questions. Thank you.
Thank you, Dan. That was great. I really appreciate your presentation today. And there are a few questions already in the Q&A, so I'll try to moderate and start. I'd like to ask the first question, and it's sometimes it's of great value to look sort of exploit data at a national and longitudinal level and just look for associations like you're doing that might explain the relationships between or the causality relating to gun violence. And another approach maybe is to exploit more the heterogeneity in the data and evaluate particular subgroup analysis that might look at perhaps hotspots of where either in points in time or in certain regions where gun violence has suddenly increased, and try to understand what's unique about those circumstances. What are the correlates or the antecedents of that gun violence increase? And I wonder if you've thought about sort of other modeling strategies that might sort of try to understand the variability a bit more in that alternative approach.
Yeah, it's a really good question. We have started thinking about it because we know that conceptually and empirically, a high violence neighborhood that is undergoing a tremendous amount of shootings on a given year, that has high levels of concentration or concentrated disadvantage, is different in a million ways from a neighborhood that is experiencing little to no gun violence. And so one thing that we want to do is we want to look at kind of threshold effects or subgroup buckets, right? We're looking here at 15,000 neighborhoods, a real diverse range here in these cities. But what does the health fallout, again, or the associations related to gun violence exposure for that top 5% or that top 10% of neighborhood that are getting hammered by gun violence on a day-to-day basis? I would expect that we would see, stark differences in much more concentrated impacts, especially in certain types of health outcome related to mental health, but also some of the behavioral health components. People who are exercising and sleeping, going outside, the stress profile of a community, the fear profile of a community that is kind of being bombarded with gun violence on a day-to-day, I think is going to look very different than a community that has one or even two shootings in a given neighborhood, right? That 5 to 7 block radius. And so that is definitely one thing that we want to do in kind of a follow-up study to this, in addition to teasing out different health outcomes, is looking at that heterogeneity and in particular the hardest hit neighborhoods when it comes to exposure.
Great, thank you for that. Yeah, and Janice Feinberg made a comment, and I think it's a good one, just that I was suggesting zeroing in on gun violence neighborhoods, but she makes the point that neighborhoods with concentrated disadvantage have other health disparities, and we shouldn't ignore them because they don't have, they're not a gun violence hotspot. And I think that's a really good point. I don't know if you have any additional comments about that.
I think that plays into this idea that there is complex links between, kind of concentrated disadvantage, gun violence, and health outcome. And so being able to tease that out further and seeing, where gun violence is a mechanism between disadvantage and poor health, or where it's maybe kind of co-varying or acting as kind of like a parallel issue to happening. And so, yeah, I think that trying to get some of these pathways, it would be great to be able to do some change analysis over time to do that. But right now with the year over year, it's kind of in these buckets like I talked about today.
Yeah, and we had a couple other comments related to that, just that, some of the associations may be more ecological than causal. And I think that's sort of what you're saying is sort of in the limitations of the data. But, Jeff Linder brings up a point just about, have you thought about lagging effects? I mean, I've seen some people analyze even the effects of distant, redlining communities in terms of like their effects on health today. And, the effect may not be year over year, but 2 to 3 or 4 years, it's sort of a lagging effect of some of these exposures at a community level, and then health outcomes or outcomes at other levels. So any additional comments about that in terms of like the temporality or the cause effect? How certain are you these are causal associations versus just associations?
Yeah, so in terms of causality, right, where the CLPM approach allows us to kind of look at year over year associations. And so the lagging question is one that we kind of wrestled with a lot. And because we have the 6 years, and again, a lot of that is just the constraints of when data starts to become available, when data is no longer available, we're at a relatively limited time frame. The year over year was the way that we were able to model this so that we could look consistently at least at this initial conception of neighborhood health conceived more broadly, right? To start from the premise that there are impacts that gun violence has, right? And the way that people feel those impacts of gun violence would be relatively immediate year over year, because that's how we can measure it. We can't look at month or daily data using this. I think where the lags in the longer term really comes into play is diving more into some of the mental health exposures or outcomes, and then also looking at some of the functional disabilities. So we have the ACS 6-item measures of functional disability. Can you go to the doctors? Can you do chores around the house? How hard is it for you to walk around? That kind of thing. I think it's worth looking at longer lags for that. Also longer lags for a lot of the more chronic physical and some of the mental health outcomes like depression in the CDC places data. We've started looking at those lags, but haven't gotten into it too much because we're hoping to be able to expand the data 2019 to include 2 more years through 2021 pretty soon. And we would just like to have a couple more of those years. But no doubt we need to play more with the different levels and the different thresholds we're seeing, not just in terms of type of neighborhood, but also kind of the temporal thresholds as well. So that's really well taken.
Jill Feinglass asked a question that I think relates to what really are the sources of spikes in gun violence that seem to be independent of long existing concentrated segregation and poverty. And he points out like a sort of secular trend towards declining gun violence from 2005 to 2015, and then a spike over the pandemic, and just to imply that there are other sort of features or factors that sort of underlie gun violence changes at a community level. And I'm wondering if you have any comments or thoughts about that.
Yeah, I have many thoughts about kind of heterogeneity in gun violence and violent crime more broadly. I mean, we talk all the time in my classes. It's really a multifactorial thing, right? If we're trying to understand, especially broad terms, because even going back before 2005, gun violence had been precipitously declining from 1993 through 2014, although that was not the case in all neighborhoods, so that in more disadvantaged neighborhoods, in areas that were higher percentage Black and Hispanic, the lines were a lot flatter. They weren't declining at the same rates as it was for a lot of other parts of the country. But yeah, there are these exogenous factors that I think really that are very important for thinking about variation even within some of these longer trends. And we see it when we look at the data that we have. I mean, one of the things that can make looking at these things over time challenging when we are initially trying to model the change, rather than kind of the year-over-year association approach that we've taken, was that in a lot of places, the gun violence will remain relatively stable. And so you only have so much heterogeneity to work with when you're trying to model it appropriately. But, there is everything from changes to kind of policing approaches, new interventions that come into play at the community level. So, a new cure violence, or a new community group, or a new police approach to focused deterrence that they might implement. These can have kind of shocks to rates of gun violence, up or down. And then, of course, there are also kind of more broader national things related to, televised police killings. Mass shootings can influence people going out and getting guns, and firearm supply can influence rates a little bit more long term. But there are a lot of different factors that come into play in shaping these kind of year-over-year changes. And I think that matters. We try to account for some of these things to the extent that we can. That's where concentrated disadvantage really helps. But yeah, it's a complex picture for sure.
Yeah, and on that thread, I'll ask one more question, and then in the interest of time, we'll have to close. But it relates to a theme that's in several of the the questions in the Q&A. We've got students, we've got public health educators, researchers, and professionals. We've got people interested in policy all in the audience. And several people have asked, what can we do? What can I do as a medical student? What can I do maybe through the lens of a state or local or tribal health department? What can we do through laws and regs? What would your advice be to people in terms of getting them involved in gun violence reduction or in addressing other fundamental community level deprivation issues that you highlighted today in your talk?
Yeah, it's a great question. I always like this one, and I tend to get it a lot. Since we're speaking with medical students and medical professionals, one of the areas that I think is promising, but just does not have enough research yet to fully support it, is the use of hospital-based violence intervention programs that, when paired appropriately with a community program that has violence interruption in the streets, the HVIP can be a program that takes advantage of the individual who has been shot kind of waking up that golden moment, to interrupt cycles of retaliation, to interrupt cycles of violence, of people getting out of the hospital and getting re-injured, or going to try to find the person that committed a shooting. I think that these programs, when they're properly funded, when they have the right doctors and social workers and caseworkers on them, can be really, really impactful and really powerful at an individual level, and at the community level where maybe the hospital is focused on. And so, in addition to kind of a lot of the street outreaches has been getting attention, I think hospital-based programming matters. And so I would urge anybody who is interested to learn more about their local HVIP and to see how they can get involved. My brother is a medical student, and I know that he has done this as well, finding ways that you might be able to help with that. The other thing that I often tell students and people who are very, very frustrated and feel like this is out of their hands, is that at the end of the day, in a lot of ways, this is a political issue. It's hard to avoid that, and it's hard to kind of turn your way and say, I'm just going to focus on kind of smaller actions. The firearm policies that we know can work, whether it's on the supply side of firearms or whether it's on kind of the behavioral side and in assisting people in getting victim services, they're not getting passed, they're not getting pushed through, and it's not happening at a local, state, or federal level across the country. It's happening in places like Jersey quite well, where I live, but certainly not all states. And so, acting with your vote seems like a small thing to say, and it seems like, okay, how does this matter, how does this count? But supporting the people that put this at front and center of their campaign, or put this at front and center of their agenda to actually push forward. We're seeing this in Nashville right now, that kind of clash But I think that the push needs to come harder, and that can help with people running and people voting. That allows this to escalate to a bigger level that can have broader impact.
Thank you again, Dan. We have several really great questions, and I apologize to folks in the audience. We weren't able to get through them all by the top of the hour. I'm going to ask Adela, if we can, to sort of send those along to you, if you're able to kind of take a look at them. If you have any thoughts or comments, we'd like to share it back with the audience. Just a lot of interest in your talk today, a lot of provocative and interesting questions, and I don't want to dismiss them. So thank you again so much, and really appreciate your time today. And thanks everybody for joining.
Thanks so much, Ron.